The syringe trembles in my hand. I can feel the cold sweat forming at the base of my neck, trickling down between my shoulder blades beneath the surgical scrubs. The overhead lights in the pre-op suite are too bright, washing everything in harsh white that makes the sterile instruments gleam like accusations. Mr. Wallace lies on the gurney before me, his weathered hands gripping the metal rails so tightly his knuckles have gone bone white. His eyes, sharp, alert, piercing, are locked onto mine with an intensity that makes my breath catch. "You made a mistake," he says again, his voice low but steady. Not angry, not panicked, just certain. The words hang in the air between us like smoke. My attending physician, Dr. Miriam Chen, stands across from me, her expression unreadable behind her surgical mask. The anesthesiologist has paused mid-motion, one hand hovering over the IV line. Even the surgical tech has stopped arranging instruments on the tray, the soft clink of metal gone silent. Everything has stopped. My heart pounds against my ribs so hard, I'm certain everyone can hear it. I've triple-checked everything. The chart, the consent forms, the imaging, the blood work, everything matched. Everything was perfect, wasn't it? Mr. Wallace's eyes never leave mine. "I need you to listen to me very carefully, Dr. Reyes," he whispers. "Before you put me under, you made a mistake." But what I was about to discover wasn't just a mistake. It was the difference between life and death, hidden in a place no one thought to look. 6 hours earlier, the morning had started like any other Tuesday at St. Halsted Hospital. I arrived at 5:47 a.m., the sky still dark, the parking lot nearly empty except for the scattered vehicles of night shift workers finishing their rotations. The coffee in my travel mug was already lukewarm, but I drank it anyway, feeling the bitter liquid coat my tongue as I walked through the automatic doors into the fluorescent brightness of the main entrance. The lobby smelled like disinfectant and the faint sweetness of cafeteria pastries. Security guard Marcus gave me his usual nod from behind the desk, his radio crackling with some distant communication I couldn't quite make out. I swiped my ID badge, heard the electronic beep, watched the turnstile light turn green. Another day, another chance to prove myself. My residency at St. Halsted had been everything I'd dreamed of and everything I'd feared, often simultaneously. The hospital itself was a sprawling complex of glass and steel, 9 stories of some of the most advanced medical technology in the region, serving a city of nearly 400,000 people. It was the kind of place where medical students competed fiercely for residency spots, where attending physicians published papers that changed protocols nationwide, where every day brought cases that could become teaching moments or cautionary tales. I was 3 months into my first year of internal medicine residency. 3 months of barely sleeping, of studying late into the night, of second-guessing every decision, of watching more experienced doctors work with a confidence I desperately wanted to possess, but couldn't quite grasp yet. The elevator carried me to the 5th floor, internal medicine. The doors opened to reveal the familiar organized chaos of morning preparations. Nurses moved with practiced efficiency between patient rooms, their shoes squeaking softly against the polished linoleum. Somewhere down the hall, a monitor was beeping its steady rhythm. The medication cart rattled as someone pushed it past the nursing station. I checked my watch. 5:53 a.m. Morning rounds started at 6 m sharp. Dr. Chen didn't tolerate lateness. I found her already in the conference room, surrounded by patient charts spread across the long table, like an intricate puzzle only she could solve. Dr. Miriam Chen was in her mid-40s, rail-thin, with sharp features and sharper intellect. She wore her black hair pulled back in a tight bun, silver-framed glasses perched on her nose, and had a reputation for being one of the most demanding attendings in the hospital, and one of the best. "Dr. Reyes," she said, without looking up from the chart she was reviewing. "You're early." "Yes, Dr. Chen." "Good. We have a full board today. 14 patients on our service, 3 new admits overnight, and 1 scheduled procedure this afternoon." She finally looked up, her dark eyes assessing me with that particular intensity she reserved for teaching moments. "How many hours did you sleep last night?" The question caught me off guard. "About 5, maybe 5.5. Not enough, but better than most residents manage." She pushed a chart across the table toward me. "This is your case for today. Gerald Wallace, 72 years old, scheduled for a minimally invasive cardiac procedure this afternoon. You'll be assisting." My pulse quickened. Assisting on a cardiac procedure was exactly the kind of experience I needed. I pulled the chart closer, my eyes scanning the information hungrily. "Mr. Wallace presented to his cardiologist 3 weeks ago with intermittent chest pain and shortness of breath," Dr. Chen continued, her voice taking on the pedagogical tone she used when teaching. Stress tests showed significant abnormalities. Subsequent cardiac catheterization revealed a 90% blockage in his left anterior descending artery. The plan is to place a drug-eluting stent this afternoon. I nodded, absorbing every word. Has he had any previous cardiac interventions? None. First significant cardiac event. But his medical history is extensive. Type 2 diabetes, hypertension, hyperlipidemia, classic risk profile. She paused. What else do you want to know? This was another test. Dr. Bao. Chen never simply gave information. She made you work for it. Made you think like a doctor instead of a student memorizing facts. Family history? I asked. Father died of MI at 65. Mother had stroke at 70. Current medications? Metformin, lisinopril, atorvastatin, aspirin, all compliance verified. Any drug allergies? None documented. Recent labs? She slid another sheet across the table. Complete metabolic panel, CBC, coagulation studies, all within normal limits for his age and conditions. Renal function is good. No contraindications for contrast dye. I studied the numbers, the neat rows of data that supposedly told the complete story of a human body's inner workings. Everything looked appropriate. Everything aligned with the procedure plan. He seems like a straightforward case, I said carefully, knowing that in medicine, nothing was ever truly straightforward. Dr. Chen's expression didn't change, but something flickered in her eyes. Approval or warning, I couldn't tell. No case is straightforward, Dr. Reyes. Every patient is a collection of variables we can measure and variables we can't. Your job is to pay attention to both. Yes, Dr. Chen. You'll meet Mr. Wallace this morning during rounds. Review his chart thoroughly. Understand not just what we're doing, but why we're doing it. The procedure is scheduled for 2 p.m. in the cardiac cath lab. I expect you to be prepared. I will be. She gathered the charts with brisk efficiency. Let's begin rounds. The next 2 hours passed in the familiar rhythm of morning rounds, moving from room to room, patient to patient, each one a unique story written in medical terminology and human vulnerability. Mrs. Patterson in 517, recovering from a severe pneumonia, her oxygen saturation finally stable after 3 days of intensive antibiotics. She smiled weakly when we entered, her daughter holding her hand and asking questions about when she could go home. Mr. Dimitri in 522, newly diagnosed with cirrhosis, his yellowed eyes reflecting the fear he tried to hide behind gruff complaints about the hospital food. Dr. Chen explaining in careful terms what the diagnosis meant, what treatment would look like, never promising more than medicine could deliver. Ms. Rodriguez in 509, a young woman barely older than me, newly diagnosed with lupus, crying softly as Dr. Chen outlined the treatment plan with unusual gentleness. Each patient reminded me why I'd chosen this path. My parents had sacrificed everything to give me opportunities they'd never had. My father working construction in Houston's brutal summers, my mother cleaning office buildings at night, both of them immigrants who'd crossed borders and overcome barriers so their son could wear a white coat and help people heal. I couldn't fail them. I wouldn't. Room 531 was at the end of the corridor, next to the large window that overlooked the hospital's courtyard garden. The morning sun was finally breaking through the clouds, casting long shadows across the tile floor. Dr. Chen knocked twice, her standard protocol, and pushed open the door. "Good morning, Mr. Wallace." The man in the bed looked up from the newspaper he'd been reading, folding it carefully and setting it aside. Gerald Wallace had the kind of face that spoke of decades spent outdoors. Weathered skin, deep lines around his eyes, a certain ruggedness that even the hospital gown couldn't diminish. His gray hair was neatly combed, and despite being in a hospital bed awaiting a cardiac procedure, he sat upright with the posture of someone accustomed to staying in control. "Dr. Chen," he said, his voice carrying a slight Texas drawl. "Good morning. How are you feeling today?" "Nervous," he admitted with a half smile, "but ready to get this done." "That's understandable. Mr. Wallace, this is Dr. Noah Reyes, one of our internal medicine residents. He'll be assisting with your procedure this afternoon." Mr. Wallace extended his hand, and I shook it, noting the firm grip, the calluses that spoke of manual labor, the slight tremor that might have been anxiety or might have been something else. "Pleased to meet you, doctor," he said, his blue eyes studying my face with the same intensity I'd been trained to use when examining patients. "You look awful young." I smiled, having heard variations of this observation countless times. "I graduated medical school last year, sir, but I'm in excellent hands with Dr. Chen, and so are you." "I don't doubt it. His expression grew more serious. I've been reading about this procedure. Seems fairly routine these days. Dr. Chen pulled up a chair, gesturing for me to do the same. This was another teaching moment. How to talk to patients, how to build trust, how to explain complex medical concepts in terms people could understand without being condescending. It is routine, Dr. Chen said, but that doesn't mean we don't take it seriously. Dr. Reyes, would you explain to Mr. Wallace what we'll be doing this afternoon? I took a breath, organizing my thoughts. Of course. Mr. Wallace, you have a significant blockage in one of the major arteries that supplies blood to your heart, the left anterior descending artery. What we'll do this afternoon is insert a thin catheter through an artery in your wrist or groin, thread it up to your heart, and use imaging to guide us to the blockage. Then we'll place a small mesh tube called a stent to hold the artery open and restore proper blood flow. He nodded slowly. And I'll be awake for this? You'll be sedated but conscious. You might feel some pressure but no significant pain. The entire procedure usually takes about an hour. What are the risks? His question was direct, his gaze unwavering. Dr. Chen took over. All procedures carry risks. In your case, the risks include bleeding, infection, damage to the artery, allergic reaction to the contrast dye, or in very rare cases, heart attack or stroke. However, the risk of doing nothing, of leaving that blockage in place, is significantly higher. You've been having chest pain. That blockage is a time bomb. We need to fix it. Mr. Wallace was quiet for a moment, processing this information. I could see him weighing options, calculating odds in his own way, not with the clinical precision of medical training, but with the practical wisdom of someone who'd faced difficult decisions before. I trust you, he said finally. Both of you. Something in his tone made me pay closer attention. There was a weight to those words, a gravitas that suggested they weren't spoken lightly. Dr. Chen stood. We'll see you in pre-op at 1:30. Try to rest this morning. Don't eat or drink anything. I know, he interrupted gently. They've told me multiple times. Nothing by mouth after midnight. Good. Dr. Chen made a note in his chart. Do you have any other questions? Mr. Wallace hesitated, and I saw something cross his face. A flicker of uncertainty, maybe, or concern. But then it passed, and he shook his head. No questions. I'll see you this afternoon. We left the room, continuing rounds to the remaining patients. But as we moved through the rest of the morning, I kept thinking about Mr. Wallace, about that moment of hesitation, about the way he'd looked at me as if he was trying to determine something important. At 11:30 a.m., I finally had a chance to grab lunch, a rushed 15 minutes in the cafeteria, eating a sandwich I barely tasted while reviewing Mr. Wallace's chart one more time on my tablet. Everything was in order. I'd checked and rechecked. The cardiac catheterization report from 3 weeks ago showed the 90% LAD blockage clearly. The echocardiogram demonstrated good left ventricular function overall, with some wall motion abnormalities consistent with the blockage location. The EKG showed subtle changes indicating possible ischemia. His labs were perfect for the procedure. His consent form was signed and dated, every risk discussed and acknowledged. I'd even called down to the cath lab to confirm the equipment would be ready, spoken with the interventional cardiologist Dr. Marcus, who would be performing the actual stent placement, reviewed the sedation protocol with anesthesiology. Everything was perfect. So why did I feel this nagging unease, this small voice in the back of my mind suggesting I was missing something? I pushed the feeling aside. First-year resident anxiety. Nothing more. Dr. Chen had reviewed everything. Dr. Marcus had reviewed everything. Multiple attending physicians had signed off on this procedure. I was just overthinking, letting my natural nervousness manifest as false intuition. I finished my sandwich, threw away the trash, and headed back upstairs to prepare. At 1:15 p.m., I changed into surgical scrubs in the locker room, the stiff fabric still slightly uncomfortable, the drawstring tied tight around my waist, the surgical cap covering my hair. I scrubbed my hands at the sink, the antibacterial soap turning to foam between my fingers, counting the required 30 seconds while watching myself in the mirror. I looked young. Mr. Wallace had been right about that. 27 years old, barely 3 months into residency, still learning the difference between textbook medicine and real medicine, still building the confidence that came with experience I didn't yet have. But I was careful, thorough. I checked everything twice, then 3 times. I wouldn't let anyone down. I dried my hands with paper towels and pushed through the door into the pre-op suite. Dr. Chen was already there, reviewing something on a tablet. The anesthesiologist, Dr. Sandra Williams, was setting up her equipment. A surgical tech whose name tag read James was arranging instruments on a steel tray with meticulous precision. And on the gurney, dressed in a hospital gown, IV already in place, was Mr. Wallace. He looked smaller somehow, more vulnerable without his street clothes, without the newspaper to focus on, without the control that came from sitting upright in his regular hospital bed. But his eyes were still alert, still sharp, tracking every movement in the room. "Mr. Wallace," Dr. Chen said, approaching the gurney. "How are you feeling?" "Ready as I'll ever be," he replied, his voice steady despite the slight tremor in his hands. "Good. Doctor, Reyes is going to do one final check of your chart and verify everything with you. Then we'll get started. Dr. Marcus is scrubbing in now. He'll be joining us shortly." I stepped forward, pulling up Mr. Wallace's chart on the mobile workstation. This was standard protocol. Verbal verification of identity, procedure, and site, even though everything had been checked multiple times already. "Mr. Wallace, can you state your full name and date of birth for me?" "Gerald Thomas Wallace, March 14th, 1953. I checked the chart. Perfect match. "And can you tell me in your own words what procedure you're having today?" "You're going to put a stent in my heart, in the artery that's blocked." "That's correct. Specifically, we're treating the left anterior descending artery." I showed him the consent form. "This is your signature here, correct?" "Yes." "And you understand the risks we discussed? Bleeding, infection, artery damage, allergic reaction, and the rare possibilities of heart attack or stroke?" "I understand." Everything was proceeding exactly as it should. I glanced at Dr. Chen, who gave me a small nod of approval. This was good. I was being thorough, professional, careful. Dr. Williams stepped forward. "Mr. Wallace, I'm going to start giving you some medication to help you relax. You'll feel drowsy, but you'll still be able to respond to us. Is that all right?" "That's fine." She adjusted something on the IV line. I watched Mr. Wallace's face, expecting to see the gradual relaxation that came with the sedation, the softening of features that indicated the medication was taking effect. But instead, his eyes widened. His hand shot out, gripping the rail of the gurney with sudden force. "Wait," he said, his voice sharp, cutting through the quiet efficiency of the pre-op suite. "Wait." Dr. Williams paused, her hand still on the IV line. Dr. Chen looked up from her tablet, her expression shifting from routine focus to heightened attention. "Mr. Wallace?" Dr. Chen said. "What's wrong?" He was breathing faster now, his chest rising and falling rapidly beneath the thin hospital gown. But it wasn't panic I saw in his eyes. It was something else. Determination. Urgency. He looked directly at me. "You made a mistake," he said. The words landed like a physical blow. I felt my stomach drop, felt the sudden rush of adrenaline that came with alarm bells ringing in my mind. "What?" I managed to say. "You made a mistake," he repeated, his voice low but absolutely certain. "I need you to listen to me very carefully, Dr. Reyes. Before you put me under, you made a mistake." "Doctor?" Chen moved closer to the gurney, her body language shifting into the alert posture of a physician preparing for a crisis. "Mr. Wallace, what mistake are you referring to?" But he kept his eyes locked on mine, ignoring everyone else in the room. "Something's wrong. You need to check again." My mind was racing. Had I missed something in the chart? Had I transposed numbers, overlooked a lab value, failed to see some contraindication that was obvious to everyone except me? "Mr. Wallace?" I said, forcing my voice to remain calm despite the panic rising in my chest. "I've reviewed your chart multiple times. Everything has been verified. Can you tell me specifically what you think is wrong?" "I don't think anything," he said, his grip on the rail not loosening. "I know, and you need to figure it out before you do this procedure." Dr. Williams had stopped the sedation completely now, stepping back from the IV line. James had frozen in place, holding a sealed surgical instrument package. The only sound was the soft beeping of the monitors and the pounding of my own heartbeat in my ears. Dr. Chen's voice cut through the tension, sharp and commanding. "Everyone stop!" She looked at Mr. Wallace, her expression unreadable. "Mr. Wallace, you understand that stopping now means delaying your procedure. If you're having second thoughts about—" "I'm not having second thoughts about the procedure," he interrupted, his voice rising slightly. "I'm telling you that something is wrong with the information you have. And if you go ahead with this procedure without figuring out what it is, someone is going to get hurt." "Someone?" Dr. Chen said carefully. "Do you mean you? Are you experiencing symptoms right now? Chest pain, shortness of breath, numbness?" "No. I mean someone is going to get hurt because you have the wrong information." "The wrong information." The words echoed in my head. I'd checked everything. The name matched. The date of birth matched. The procedure site matched. The consent was signed. The labs were current. The imaging was clear. What could possibly be wrong? But even as I thought it, that nagging feeling I'd had earlier, that small voice suggesting I was missing something, grew louder, impossible to ignore now. Dr. Chen looked at me, her eyes asking a question. Do you know what he's talking about? I shook my head slowly. I didn't, but I knew I had to find out. Dr. Williams, please delay the sedation, Dr. Chen said, her voice returning to its usual controlled efficiency. James, give us the room for a moment. She waited until the surgical tech had left before turning back to Mr. Wallace. All right, you have our complete attention. What exactly do you think we've gotten wrong? Mr. A. Wallace took a breath, his knuckles still white on the gurney rail. When he spoke, his voice was quieter, but no less intense. 3 weeks ago, I went to my cardiologist because I'd been having chest pain. They did tests. They found the blockage. They scheduled this procedure. He paused. But yesterday morning, something happened, and I realized that if I didn't say something now, before you put me under, it might be too late. What happened yesterday morning? I asked. His eyes met mine again, and I saw something in them that made my breath catch. Not fear exactly, but a kind of desperate certainty. The look of someone who knows they're right, but doesn't know if anyone will believe them. I met another Gerald Wallace, he said, in the hospital lobby. We got to talking. Turned out he's here for a procedure too. Different floor, different doctors, but same name. Same first and middle name, actually. Gerald Thomas Wallace. The room went very still. Dr. Chen's expression didn't change, but I saw her hand tighten around the tablet she was holding. Dr. Williams had gone pale. And when I heard his name, Mr. Wallace continued, his voice steady despite the tremor in his hands. When I heard that he was having a procedure today too, I got worried, because mistakes happen. I know they do, and I need you to prove to me that you have the right Gerald Wallace. But what I was about to discover, as I stood there with the syringe trembling in my hand and the weight of Mr. Wallace's words pressing down on me, wasn't just about mistaken identity. It was about the razor-thin margin between routine and catastrophe, about the difference between confidence and complacency, about how a single overlooked detail could mean the difference between life and death. And the truth was hidden in a place I should have looked but never thought to check. My hands had gone numb. I could hear the blood rushing in my ears, a sound like distant ocean waves that threatened to drown out everything else. Dr. Chen had already moved to the computer workstation, her fingers flying across the keyboard with practiced speed. Date of birth again, she said, her voice tight. March 14th, 1953, Mr. Wallace replied. I watched the screen over her shoulder, seeing the patient information database loading, seeing the search results populate. My throat was dry. I tried to swallow and couldn't. 2 results. Wallace, Gerald Thomas, DOB 03 14 1953, MRN 847392, Wallace, Gerald Thomas, DOB 03 14 1953, MRN 847395. 2 different medical record numbers, 3 digits apart. Both patients admitted to St. Halstead Hospital, both with procedures scheduled for today. Oh, God, Dr. Williams whispered. Dr. Chen clicked on the first record, the one I'd been reviewing all morning. Gerald Thomas Wallace, 72 years old, cardiac catheterization with stent placement scheduled for 2:00 p.m. in Cath Lab 2, room 531. Then she clicked on the second record. Gerald Thomas Wallace, 72 years old, orthopedic surgery scheduled for 2:30 p.m. in OR 4, hip replacement, room 318. Different floors, different specialties, different procedures entirely, but the same name, the same birth date, the same age. I felt like I was falling, like the ground had opened beneath me and I was plummeting into a void where nothing made sense anymore. How was this possible? We had protocols, we had verification systems, we had layers upon layers of safety checks designed to prevent exactly this kind of confusion. Which room are we in? Dr. Chen's question was directed at me, her voice cutting through my spiraling panic. Pre-op suite 3, I managed to say. Outside Cath Lab 2. She pulled up the pre-op scheduling system, her movements sharp and precise despite what must have been her own rising alarm. The screen showed today's schedule, each procedure listed with patient name, medical record number, procedure type, and assigned location. 2 Zagayus p.m., Cath Lab. 2 Wallace, Gerald Thomas, MRN 847392, cardiac catheterization with stent placement. 2:30 p.m., OR 4, Wallace, Gerald Thomas, MRN 847395, total hip replacement. Mr. Wallace, Dr. Chen said, turning back to the gurney. What room number are you staying in? 531, he answered. 5th floor, end of the hall. She looked at the computer screen again, verifying. MRN 847392, the cardiac patient, was indeed listed as being in room 531, which meant the man lying on the gurney in front of us, the man who'd stopped us just moments before we would have sedated him, the man whose instinct had potentially saved us from a catastrophic error, was the correct Gerald Wallace. We had the right patient. But that meant somewhere else in this hospital, in an orthopedic pre-op area, another Gerald Thomas Wallace was being prepared for a hip replacement he needed. Or was he? The thought struck me like lightning, sudden and illuminating and terrifying. If there had been confusion about which Gerald Wallace was which, if somehow the records had gotten mixed up in the system, if someone else had made an error earlier in the chain of events. Dr. Chen, I said, my voice coming out strangled. We need to check the other pre-op area. Now! She was already moving, yanking open the door to the pre-op suite and calling out into the hallway. I need a nurse. Someone find me the charge nurse immediately. A nurse I recognized, Lisa Martinez, who'd been on this floor for years, came running, her expression shifting from routine efficiency to alarm at the urgency in Dr. Chen's voice. What's wrong? I need you to call up to OR4's pre-op area right now, Dr. Chen commanded. They have a patient scheduled for hip replacement at 2:30. Gerald Thomas Wallace, MRN 847395. I need to know if that patient is currently in their pre-op suite and if they've started any procedures on him yet. Lisa didn't ask questions. She pulled out her phone, dialing quickly, her face grave. We all waited, the silence broken only by the sound of her breathing and the distant hospital sounds from beyond the room. This is Lisa Martinez from cardiology, she said into the phone. I need to speak to whoever's in charge of your pre-op area right now. Yes, it's urgent. Very urgent. She listened, her expression growing more concerned. Are you certain? Another pause. And you've verified his identity? Has he confirmed his procedure? Longer pause. No, don't start anything. Don't give him any medications. We're sending someone up right now. She ended the call and looked at Dr. Chen with wide eyes. They have a Gerald Wallace in their pre-op suite. He's confirmed his identity, confirmed his procedure. They were just about to start his sedation when I called. Dr. Chen's jaw tightened. Did they verify his medical record number? They said they followed standard protocol, name, date of birth, procedure verification, but not the MRN, Dr. Chen said, and it wasn't a question. Dr. Reyes, stay with this Mr. Wallace. Dr. Williams, you too. No one gives him any medications until I get back and we sort this out completely. Lisa, come with me. They were gone before I could respond, the door swinging shut behind them with a soft pneumatic hiss. I stood frozen, staring at Mr. Wallace, who was looking back at me with an expression that was equal parts vindication and concern. I was right, he said quietly. Wasn't I? Yes, I whispered. You were right. Dr. Williams moved closer to the gurney, checking the monitors out of what seemed like pure habit rather than medical necessity. His vital signs were stable, blood pressure slightly elevated, probably from stress, but nothing alarming. Heart rate in the 80s. Oxygen saturation 98% on room air. Physically, he was fine. But mentally, emotionally, we'd just come within minutes, maybe seconds, of doing a cardiac procedure on the wrong patient. Or worse, of doing a cardiac procedure on a patient who didn't need one, while the patient who actually did need it went to surgery for his hip. The scenarios spiraling through my mind were nightmarish. What if we hadn't caught this? What if Mr. Wallace hadn't said something? What if he'd just trusted us, trusted the system, trusted that hospitals don't make mistakes this fundamental? We would have sedated him. We would have threaded a catheter through his arteries. We would have injected contrast dye. We would have looked at his heart through fluoroscopy. And we would have found, what? Normal coronary arteries? No blockage? Would we have been confused? Would we have rechecked the records then? Or would we have assumed the blockage had somehow resolved on its own, had been less severe than the previous catheterization suggested? And meanwhile, the other Gerald Wallace, the one who actually had the 90% LAD blockage, the one whose chest pain was a warning sign of imminent cardiac catastrophe, would have been in an operating room having orthopedic surgery with no one knowing. He was a ticking time bomb. The hip replacement itself might have been the trigger. The stress of surgery, the anesthesia, the physiological demands on his cardiovascular system. His blocked artery could have caused a massive heart attack right there on the operating table. He could have died. We could have killed him through sheer institutional confusion, through the statistical improbability of two men with identical names and birth dates being in the same hospital on the same day for different procedures. Dr. Reyes, Mr. Wallace's voice pulled me from my spiraling thoughts. I looked at him, really looked at him, seeing the weathered face, the sharp eyes, the steady gaze of someone who'd just prevented a disaster through nothing more than paying attention and speaking up. "Yes, sir? You're pale. You should sit down." "I'm fine," I said automatically, then realized I wasn't fine at all. My legs felt shaky. My hands were still trembling. The adrenaline that had flooded my system was beginning to ebb, leaving behind a queasy exhaustion. "Sit down anyway," he said, his voice gentle but firm. "You're not going to be any good to anybody if you pass out." I pulled over a rolling stool and sat, grateful for the support. Dr. Williams glanced at me with concern but said nothing. Her attention split between the monitors and the door, waiting for Dr. Chen to return. "I should have caught this earlier," I said, the words tumbling out before I could stop them. "I reviewed your chart 3 times, 4 times, I checked everything, but I never thought to search for—" I trailed off, unable to finish the sentence. Unable to articulate the fundamental assumption I'd made, that when I pulled up the record for Gerald Wallace, room 531, scheduled for cardiac catheterization, I was looking at the one and only Gerald Wallace in the hospital. "How are you supposed to know?" Mr. Wallace said. "It's not like it's a common occurrence, 2 people with the exact same name and birthday being in the same hospital at the same time. That's not an excuse. We have systems, protocols. The medical record number is supposed to prevent exactly this kind of confusion. I should have verified it explicitly, should have what?" he interrupted. "Should have known to check for something that probably has never happened in this hospital before? Should have anticipated a 1 in a million coincidence." "Yes," I said miserably. "That's exactly what I should have done. That's what being careful means. That's what being thorough means." He was quiet for a moment, his expression thoughtful. When he spoke again, his voice was measured, almost philosophical. "Let me tell you something, Dr. Reyes. I spent 40 years as a plant supervisor in a manufacturing facility. We made industrial pumps, big complex machinery. And you know what the most important thing I learned was?" I shook my head. "That you can't anticipate everything. You can have all the protocols in the world, all the safety checks, all the redundant systems. But eventually, something happens that nobody planned for. Some combination of circumstances that shouldn't happen but does anyway. And when that happens, you have 2 choices. You can freeze up or you can deal with it. But someone could have died because of my mistake. No one died. And you know why? Because when I spoke up, you listened. You didn't dismiss me. You didn't tell me I was confused or scared or that I should just trust the system. You took me seriously." He paused. "That matters more than you realize." The door opened and Dr. Chen strode back in, her face flushed, her expression stormy. Behind her came Lisa and 2 other people I didn't immediately recognize. A tall man in surgical scrubs and an older woman in administrative attire with a hospital ID badge that marked her as someone from risk management. "We have a situation," Dr. Chen announced, her voice tight with controlled anger. "The other Mr. Wallace, the one upstairs in orthopedic pre-op. His medical record number is 847392. The cardiac patient. He confirmed his name and birth date. He confirmed he was having a procedure today. But when we asked him to describe the procedure, he said hip replacement." My stomach dropped further. "So the records got switched." "Not switched, mixed up." She pulled up something on the tablet, her movements sharp. Somehow, when the patients were admitted, the registration system created 2 accounts with transposed numbers. Both patients answered to the correct names and birth dates, but the procedure information got attached to the wrong records. "How is that even possible?" Dr. Williams asked, her voice incredulous. The woman from risk management stepped forward, her expression professionally neutral, but her eyes betraying deep concern. "We're investigating the root cause now. It appears there was a registration error yesterday afternoon when the second Mr. Wallace was admitted. The system should have flagged the duplicate demographic information, but for reasons we don't yet understand, it didn't." "So what now?" I asked. Dr. Chen looked at me, and for the first time since I'd started my residency under her supervision, I saw something in her expression that looked almost like respect. "Now we fix it. The orthopedic patient, the real MRN 847392, is being moved back to his correct room with his correct chart. His hip replacement is being delayed until we can completely verify everything. And this Mr. Wallace, she gestured to the man on the gurney. We're going to take extra time to triple verify every single detail before we proceed with his cardiac procedure. Will we still do it today? Mr. Wallace asked. Do you want to? Dr. Chen's question was pointed. After all this confusion, after coming within minutes of having the wrong procedure, would you still trust us to do this today? The room went quiet. It was a fair question, more than fair. If I were in his position, I wasn't sure I'd trust the hospital at all anymore, let alone agree to let us put a catheter in my heart within the next hour. But Mr. Wallace surprised me. Yes, he said firmly, because now I know you're being careful. Now I know you're paying attention. And honestly, Dr. Chen, I'd rather have you, someone who just went through this scare and is going to be hypervigilant, doing my procedure than someone who hasn't been reminded lately that mistakes can happen. Dr. Chen's expression softened fractionally. That's remarkably trusting of you. I told you before, I trust you, both of you. He looked at me. Especially now. The woman from risk management cleared her throat. Dr. Chen, we'll need detailed reports from everyone involved, and I'll need to interview both Mr. Wallaces to understand their perspectives on what happened. Fine, but after we finish this procedure, my patient needs this stent, and we've already delayed long enough. She nodded reluctantly. Agreed. But I'll be observing, if that's acceptable, as long as you stay out of the way. Dr. Chen turned back to the workstation, pulling up Mr. Wallace's chart. The correct chart, verified now multiple times, with the medical record number explicitly confirmed. She went through every detail again, reading aloud for all of us to hear. Patient name, Gerald Thomas Wallace. Medical record number, 847395. Date of birth, March 14th, 1953. Room, 531. Procedure, cardiac catheterization with drug-eluting stent placement for 90% blockage of left anterior descending artery. Previous cardiac catheterization performed on, she read off the date, showing significant stenosis requiring intervention. She looked at Mr. Wallace. Is all of that correct? Yes. You are Gerald Thomas Wallace, born March 14th, 1953, currently staying in room 531 on the 5th floor, and you are scheduled for a cardiac procedure to place a stent in your blocked heart artery. Is that correct? Yes, that's correct. Have you had previous heart surgeries or heart procedures? No, this is my first. Have you ever had a hip replacement? No. Do you need a hip replacement? A ghost of a smile crossed his face. Not that I know of. My hips work fine. Doctor. Chen nodded, satisfied. She pulled out her phone and made a call. Dr. Marcus, it's Chen. We've had a complication with identity verification. No, the patient is fine. Yes, we're still proceeding, but we need you to personally verify everything when you arrive. I'll explain when you get here. She ended the call and looked around the room at all of us. Me, Dr. Williams, Lisa, the risk management observer. Here's how we're going to proceed. Dr. Reyes, you are going to re-verify every single piece of information in that chart, out loud, starting from the top: medical history, medications, allergies, labs, imaging, everything. Dr. Williams, you verify it against your anesthesia records. Lisa, you cross-reference with the nursing documentation. I want 4 sets of eyes on every data point. Yes, Dr. Chen, I said, standing up from the stool, grateful to have a concrete task, grateful for the chance to redeem myself through meticulous care. I pulled the chart up on the tablet and began reading aloud, my voice steadier now, focusing on each detail with laser precision. Patient name, Gerald Thomas Wallace. Medical record number, 847395. The next 30 minutes passed in painstaking verification. Every medication was checked against the pharmacy records. Every lab value was cross-referenced with the laboratory system. Every piece of imaging was pulled up and reviewed, the dates confirmed, the findings documented. Dr. Marcus arrived halfway through this process, a short, energetic man in his 50s with close-cropped gray hair and the confident demeanor of someone who'd performed thousands of cardiac procedures. Dr. Chen pulled him aside and explained the situation in hushed tones. I watched his expression shift from confusion to alarm to grim determination. He approached Mr. Wallace's gurney and extended his hand. Mr. Wallace, I'm Dr. Marcus. I'll be performing your procedure today. I understand we've had quite a scare. That's putting it mildly, Mr. Wallace replied, shaking his hand. I want you to know that I've reviewed your records personally, all of them. The catheterization from 3 weeks ago clearly shows the blockage we need to address. Your symptoms are consistent with significant coronary artery disease. This procedure is medically necessary and appropriate for you specifically. I believe you. Good. But I also want you to know that if you've changed your mind, if you want to reschedule, if you want a second opinion, that is completely reasonable given what just happened. Mr. Wallace shook his head. No. Like I told Dr. Chen, I'd rather have a team that's being extra careful right now than wait and have this happen all over again with different doctors who might not catch it. Dr. Marcus nodded slowly. Then let's do this right. He turned to me. Dr. Reyes, I understand you're the resident assisting today. Walk me through the case. I took a breath and began reciting everything I'd learned, everything I'd verified, everything that made this case straightforward from a medical perspective, even as the circumstances surrounding it were anything but straightforward. Gerald Thomas Wallace, 72 years old, presented with progressive angina and dyspnea on exertion. Stress test was markedly positive. Cardiac catheterization 3 weeks ago showed 90% stenosis of the proximal LAD. Left ventricular function is preserved with an ejection fraction of 55%. No prior cardiac interventions. Risk factors include hypertension, hyperlipidemia, diabetes mellitus type 2. Currently taking metformin, lisinopril, atorvastatin, and aspirin. No known drug allergies. Recent labs show good renal function, normal CBC appropriate coagulation studies. No contraindications to contrast media or antiplatelet therapy. Dr. Marcus listened carefully, nodding at appropriate points. And the plan? Radial artery access, cardiac catheterization with left heart catheterization, and coronary angiography, followed by PCI with drug-eluting stent placement to the LAD lesion. Post-procedure, he'll be monitored overnight with repeat labs to ensure no complications. Correct. Dr. Chen, do you have anything to add? No, Dr. Reyes has covered everything. I'll be supervising throughout the procedure. Dr. Marcus looked at the clock on the wall. It was now 2:45 p.m., 45 minutes past our original start time. Then let's get started. Mr. Wallace, are you ready? I've been ready, he said with a slight smile. Let's do this. Dr. Williams stepped forward again, checking her sedation medications. I'm going to start the medications now, Mr. Wallace. You'll feel relaxed and drowsy, but you'll still be able to respond if we need you to. Is that all right? That's fine. She adjusted the IV line, and I watched as the medications began flowing into Mr. Wallace's system. This time, there was no sudden grip on the gurney rail, no alarmed voice stopping us. This time, his features gradually softened. His breathing became deeper and more regular. His eyes drifted half-closed. How are you feeling? Dr. Williams asked. Floaty, he murmured, the word slightly slurred. Sinise. She nodded, satisfied. Perfect. We're going to move you now. The transport went smoothly. Through the pre-op suite, down the short hallway, through the heavy doors into the cardiac catheterization lab. The room was dimmed, dominated by the large fluoroscopy equipment suspended from the ceiling, surrounded by monitors and imaging screens that would show us real-time views of Mr. Wallace's heart. We transferred him carefully to the procedure table, positioning him properly, draping him with sterile sheets that left only his right wrist exposed, the access site Dr. Marcus would use. I stood slightly behind Dr. Chen, trying to stay out of the way while still being able to see everything, my role primarily observational, but also ready to assist if needed. Dr. Marcus scrubbed in with practiced efficiency, his movements economical and precise. He positioned himself next to Mr. Wallace's right side, speaking in a calm, reassuring voice, even though our patient was sedated. Mr. Wallace, I'm going to numb your wrist now. You'll feel a small pinch from the local anesthetic, then just some pressure. You're doing great. I watched as he infiltrated the local anesthetic around the radial artery, waited for it to take effect, then made a small incision. The access was smooth, a testament to his experience and skill. The sheath slid into the artery, and he secured it carefully. Guide wire in, he announced, his eyes on the fluoroscopy screen as the thin wire advanced through Mr. Wallace's arterial system. Threading the catheter. The room was quiet, except for the soft beeping of monitors and the hum of the fluoroscopy equipment. I could see the catheter on the screen, a dark line advancing through the bright contrast of the vascular system, winding its way up the arm, across the chest, toward the heart. Catheter in position, administering contrast. The screen suddenly lit up with detail as the contrast dye flowed through the coronary arteries, showing the intricate network of vessels that supplied blood to Mr. Wallace's heart muscle. And there, unmistakable and stark, was the blockage. A tight narrowing in the left anterior descending artery that reduced flow to a trickle, a bottleneck that put his heart at constant risk. "There it is," Dr. Marcus said quietly. "Exactly as shown in the previous catheterization. Proximal LAD, 90% stenosis." He glanced at Dr. Chen. "This is absolutely the right patient having the right procedure." The words were meant to be reassuring, a final confirmation that we'd caught the error in time, that the man on the table was the man who needed to be here. But they also carried an unspoken weight, the acknowledgement of how close we'd come to catastrophe. "Proceeding with PCI, Dr. Marcus continued, his voice shifting back to the calm, methodical tone of someone working through a familiar procedure. Threading the wire past the lesion, I watched, fascinated despite the emotional turbulence of the past hour, as he worked with millimeter precision, advancing a thin guide wire through the narrowed section of artery, establishing a path for the stent. Wire across, positioning the balloon. The balloon catheter advanced over the wire, a tiny device that would expand to compress the plaque and make room for the stent. On the fluoroscopy screen, I could see it moving into position, perfectly placed at the site of maximum stenosis. Inflating. The balloon expanded, and on the screen, I could see the narrowing begin to open, the arterial lumen widening as the plaque was pushed against the vessel wall. Good expansion. Deflating and removing balloon, positioning stent. The stent catheter replaced the balloon, carrying the tiny mesh tube that would remain permanently in place, holding the artery open and allowing blood to flow freely again. Stent positioned. Deploying. Another inflation, this one slower and more controlled. The stent expanded, its mesh structure becoming visible on the screen as it locked into position against the arterial wall. Excellent deployment. Removing delivery system. Administering contrast to verify placement. The contrast dye flowed again, and this time the difference was dramatic. Where before there had been a tight bottleneck, now there was smooth, unobstructed flow. The left anterior descending artery carried blood freely, feeding the heart muscle that had been starving for oxygen. "Perfect," Dr. Marcus said, and I could hear the satisfaction in his voice. "No dissection, no complications. Checking the other vessels now." He repositioned the catheter, injecting contrast to visualize the other coronary arteries, the right coronary artery, the circumflex. All showed normal flow, no other blockages requiring intervention. "We're done," he announced, removing the catheter. The withdrawal was as smooth as the insertion had been. He removed the sheath from the radial artery, applied pressure to achieve hemostasis, then secured a compression band around Mr. Wallace's wrist to prevent bleeding while the puncture site healed. "Procedure complete," he said, looking around at all of us. "Time to close, 47 minutes. No complications. Patient tolerated the procedure well. Dr. Williams had been monitoring Mr. Wallace throughout, and she nodded. Vital signs are stable. He's responding appropriately. We can begin waking him up." As she adjusted the sedation, reducing the medications that had kept him in a twilight state, I felt something inside me finally begin to unclench. We'd done it. Despite the near catastrophe, despite the identity confusion, despite the terrifying realization of how thin the line was between routine and disaster, we'd done the right procedure on the right patient at the right time. Mr. Wallace's eyes fluttered open, gradually focusing on the faces around him. "How do you feel?" Dr. Marcus asked. "Tired," he murmured. "Did it work?" "It worked perfectly. The blockage is gone. Your heart is getting all the blood flow it needs now." A slow smile spread across his face. "Good. That's good." We transferred Mr. Wallace to the recovery area, where he would be monitored for the next few hours before being moved back to his room overnight. As the adrenaline finally began to ebb completely, I felt exhaustion washing over me. Not just physical fatigue, though that was certainly present, but an emotional weariness that came from having been thrust into a crisis and having to navigate through it. Dr. Chen pulled me aside as we left the recovery area, her expression serious. "Walk with me." We moved down the corridor in silence for a moment before she spoke. "What happened today is something you will never forget. I want to make sure you learn the right lessons from it." "I know I made a mistake," I said quickly. "I should have verified the medical record number explicitly. I should have—" "Stop." Her voice was sharp, cutting through my self-recrimination. "Yes, you should have verified the MRN. Yes, that's a lesson learned, but you're missing the bigger picture here." I looked at her, confused. "Dr. Reyes, today you were faced with a patient who told you something was wrong. despite having checked everything multiple times, despite having every reason to believe the system was working correctly, despite the natural human tendency to trust your own careful work. You listened. You didn't dismiss him. You didn't let your ego or your certainty override his concern, and because of that, you prevented a catastrophic error. She paused, her expression softening slightly. The ability to listen when someone tells you you're wrong, the ability to question your own certainty, that's harder to teach than any clinical skill. That's what makes a good doctor into a great one. The words settled over me like a weight and a relief simultaneously. I hadn't realized how much I needed to hear something other than criticism, how much I'd been drowning in my own guilt and fear. But I still made the initial error, I said. Yes, and you'll make others. Every doctor does. The question isn't whether you'll make mistakes, it's what you do when you realize one might have occurred. She stopped walking, turning to face me fully. Today, when Mr. Wallace spoke up, you could have gotten defensive. You could have insisted everything was correct. You could have steamrolled ahead with the procedure, confident in your preparation, but you didn't. You took him seriously. You investigated. You caught the error before it caused harm. But if he hadn't said something, but he did. And do you know why? Because you had established enough trust, enough rapport, enough of a relationship with him that he felt comfortable speaking up. If you'd been dismissive during rounds, if you'd been arrogant or rushed or indifferent, he might not have said anything. He might have just trusted that the doctors knew what they were doing and stayed quiet. I hadn't thought about it that way. Medical errors happen for many reasons, Dr. Chen continued. System failures, like what we saw today with the duplicate registrations, human fatigue, cognitive biases, time pressure. But one of the most important factors in preventing errors is creating an environment where people, patients, nurses, residents, anyone, feel empowered to speak up when something doesn't seem right. She started walking again, and I fell into step beside her. You're going to encounter situations throughout your career where someone tells you you're wrong. Sometimes they'll be mistaken. Sometimes they'll be right. The key is maintaining the humility to listen, to investigate, to question your own certainty. That's not weakness. That's wisdom. We reached the elevator bank, and she pressed the button for the 5th floor. Go home after your shift ends, Dr. Reyes. Get some sleep. Process what happened today. Tomorrow we'll write up the incident reports, participate in the root cause analysis, help the hospital improve its systems so this doesn't happen again. But for now, give yourself permission to feel everything you're feeling. The fear, the relief, the exhaustion, all of it. You earned that. The elevator doors opened and she stepped inside. Dr. Chen, I called out, stopping her before the doors closed. Thank you for teaching me, for not making me feel like a complete failure. She smiled. A real smile, not the tight professional expression I usually saw. You're not a failure, Dr. Reyes. You're a resident who just learned one of the most important lessons medicine has to teach. That makes you exactly where you're supposed to be. The doors closed, leaving me standing alone in the corridor, my white coat rumpled, my surgical cap still on my head, my body aching with fatigue. But for the first time since Mr. Wallace had said those terrifying words, "You made a mistake," I felt something other than panic and guilt. I felt grateful. 2 days later, I found myself back in room 531, but this time as a visitor rather than as part of rounds. Mr. Wallace was sitting up in bed, dressed in his own clothes rather than a hospital gown, looking considerably better than when I'd first met him. The morning light streamed through the window, casting the room in a warm glow that felt almost symbolic. Light after darkness, clarity after confusion. "Dr. Reyes," he said, smiling when he saw me. Come in. I was hoping you'd stop by before I was discharged." I entered, suddenly feeling awkward without the protective armor of my clinical role. "How are you feeling?" "Remarkably good, actually. The chest pain is completely gone. I feel like I could run a marathon." He laughed. "Though I'm told I should probably stick to walking for now." "That's excellent news. Your recovery has been smooth. No complications, no issues with the stent site. Thanks to you and Dr. Chen." He gestured to the chair beside his bed. "Sit down for a minute. I wanted to talk to you." I sat, curious and slightly apprehensive. "I've been thinking about what happened," he said, his expression becoming more serious, "about how close things came to going very wrong. And I wanted to tell you something." "What's that?" "You shouldn't beat yourself up about not catching the MRN confusion earlier. I've been talking to the nurses, the other doctors, the risk management people who've been investigating. Apparently, this was a perfect storm of system failures. The registration software had a glitch that didn't flag duplicate demographics the way it was supposed to. The admission paperwork got filed in the wrong order. The scheduling system had both of us listed under ambiguous identifiers. No single person was responsible for all of that. But I should have been more careful, I said, the guilt still lingering despite Dr. Chen's words. Maybe, or maybe you were as careful as anyone could reasonably be expected to be, and it took an unreasonable coincidence to expose the system's weaknesses. He leaned forward slightly. Here's what I think, Dr. Reyes. I think you're a good doctor precisely because you care enough to feel guilty about almost making a mistake. But I also think you need to learn the difference between reasonable vigilance and impossible perfection. The words hit me harder than I expected. I'd spent my entire life striving for perfection. Perfect grades, perfect test scores, perfect clinical performance. The idea that perfection might not be possible, that I could be a good doctor without being a perfect one, was simultaneously terrifying and liberating. Can I ask you something? I said. When you first realized there might be confusion with the other Gerald Wallace, why did you wait until we were in pre-op to say something? Why not mention it earlier? He was quiet for a moment, considering the question. Honestly? Because I wasn't completely sure. I met the other Mr. Wallace in the lobby. We chatted for a few minutes. I learned his name and that he was having surgery too. It struck me as unusual. Same first and middle name, same birthday, both here for procedures. But I thought, surely the hospital has ways of handling this. Surely they've already accounted for it. He paused, his expression rueful. It wasn't until I was lying on that gurney, watching you all prepare, seeing how certain everyone seemed, that I realized maybe nobody had accounted for it. Maybe nobody knew. And I thought if I don't say something now, if I just trust the system blindly and something goes wrong, I'd never forgive myself. Better to speak up and be wrong than to stay quiet and wonder later. You were incredibly brave to do that. I don't know about brave. Persistent, maybe. Stubborn. My wife always says I ask too many questions. He smiled. But in this case, it seems like asking questions was exactly the right thing to do. There was a knock at the door and a woman entered. Mid-60s with kind eyes and graying hair pulled back in a ponytail. She carried a bouquet of flowers and a shopping bag. "Oh, I'm sorry," she said, seeing me. "I didn't realize Gerald had a visitor." "Susan, come in," Mr. Wallace said warmly. "This is Dr. Reyes, one of the doctors who worked on my procedure. Dr. Reyes, this is my wife, Susan." She set down the flowers and extended her hand. "I can't thank you enough for taking care of my husband. When he told me what almost happened," she didn't finish the sentence, but she didn't need to. I could see the emotion in her eyes, the fear that had probably kept her awake at night, the relief that things had turned out all right. "He's the one who saved himself," I said honestly, "by speaking up when it mattered." "That sounds like Gerald," she said, moving to sit on the edge of his bed, taking his hand. "Always asking questions, always wanting to understand everything. It drives me crazy sometimes, but I guess it has its benefits. More than you know," I said. I left them a few minutes later, giving them privacy to prepare for his discharge. As I walked back down the corridor, I passed the room where the other Gerald Wallace had stayed, the orthopedic patient who'd nearly ended up in a cardiac cath lab instead of an operating room. I'd met him briefly the day after the incident, part of the hospital's follow-up process to ensure both patients understood what had happened and why. He'd been remarkably gracious about the whole thing, expressing gratitude that the error had been caught rather than anger that it had occurred in the first place. "Could have been worse," he'd said with a shrug. "At least now I know the hospital has good double-checking procedures." His hip replacement had been rescheduled and completed successfully. He was recovering well, already working with physical therapy to regain mobility. 2 Gerald Wallaces, both patients at St. Halsted, both scheduled for procedures on the same day, both navigating the complex machinery of modern medicine with its incredible capabilities and its inherent vulnerabilities, and both ultimately fine. We saw it. The incident report had been completed, the root cause analysis conducted, the system failures identified and addressed. New protocols were being implemented. Mandatory verification of medical record numbers in addition to names and birth dates, enhanced flags in the registration system for duplicate demographics, additional training for pre-op staff on identity verification procedures. The hospital would learn from this. The systems would improve. Future patients would be safer because of what had almost happened to Gerald Wallace. But beyond the systemic changes, beyond the new protocols and enhanced safeguards, what stayed with me was something more personal. The memory of standing in that pre-op suite, syringe trembling in my hand, hearing a patient tell me I'd made a mistake and having to confront the terrifying possibility that he was right. The feeling of all my careful preparation, all my meticulous checking, all my attempts at thoroughness, suddenly revealed as insufficient. The lesson that being a good doctor wasn't just about knowing medicine, it was about knowing my own limitations, maintaining humility in the face of certainty, and creating relationships where patients felt safe speaking up even when it meant questioning authority. That evening, I sat in the hospital library, a quiet space on the second floor that few people used anymore, most preferring to do their research digitally from wherever they happened to be. But I liked the stillness of it, the smell of old books, the sense of continuity with generations of doctors who'd come before me. I pulled out my phone and called my mother. It was late in Houston, but I knew she'd still be up. She always waited until I called to let her know I was okay. "Mijo," she answered, her voice warm with affection and concern. "How are you? You sound tired." "I am tired, Mama. It's been a long week." "Tell me." And I did. Not the clinical details, but the emotional arc of it. The fear, the near disaster, the patient who'd trusted his instincts enough to speak up. The attending who'd taught me that mistakes were inevitable, but how we respond to them was what mattered. My mother listened without interrupting, the way she always did, letting me process through speaking. "Your father and I, we are so proud of you," she said when I finished. "Not because you're perfect. Nobody is perfect. But because you care. Because you learn. Because when someone tells you you might be wrong, you listen instead of letting your pride get in the way. I almost hurt someone, Mama. But you didn't. You caught it in time. And now you will never make that particular mistake again. That is how you become a good doctor, not by never making mistakes, but by learning from them and making sure you don't make the same ones twice." Her words echoed Dr. Chen's, and something in that parallel, the wisdom of the experienced physician and the wisdom of my immigrant mother who'd never finished high school but understood human nature better than anyone I knew, brought unexpected tears to my eyes. "Thank you, Mama." "For what?" "For always knowing what to say." She laughed softly. "That is what mothers are for. Now go get some sleep. You sound like you need it." "I will. I love you." "I love you too, mijo. Always." I ended the call and sat in the quiet of the library for a while longer, watching the last light fade from the windows, listening to the distant sounds of the hospital, the soft beeping of monitors, the muffled voices of staff, the gentle hum of machinery that kept people alive and helped them heal. Somewhere in this building, Gerald Thomas Wallace was probably finishing his discharge paperwork, preparing to go home to his wife, to resume the life that had been interrupted by chest pain and fear, and the need for a stent in his heart. Somewhere else, the other Gerald Thomas Wallace was probably asleep in his room, recovering from hip replacement surgery, dreaming whatever dreams people dream in the strange twilight of post-operative medication. And here I sat, Dr. Noah Reyes, first-year internal medicine resident, son of immigrants, inheritor of sacrifices I could never fully repay, student of a medicine that was part science and part art and part humility. I thought about the syringe trembling in my hand, about the moment when certainty had shattered and I'd had to confront the possibility of catastrophic error. I thought about the systems we build to prevent mistakes and the human factors that sometimes cause them anyway. I thought about the patients who trust us with their lives and the awesome responsibility that comes with that trust. And I thought about the lesson I would carry forward from this moment, that being a good doctor meant being willing to question everything, including and especially myself. That it meant creating environments where patients felt safe speaking up. That it meant maintaining humility, even in the face of expertise. That it meant learning not just from my own mistakes, but from near misses, from close calls, from moments when disaster was averted by luck or timing, or someone's willingness to say, "Wait, something's not right." 3 months later, I received a letter in my mailbox at the hospital. It was handwritten, the envelope addressed in neat cursive to Dr. Noah Reyes, Internal Medicine. I opened it during a rare quiet moment in the afternoon, standing by the nursing station while I waited for a patient's labs to come back. "Dear Dr. Reyes, I hope this letter finds you well and that you haven't had any more near catastrophes with duplicate patients. I joke, but I'm sure you're being extra careful now. I wanted to write and let you know that I had my 3-month follow-up with Dr. Marcus yesterday. The stent is working perfectly. My stress test came back completely normal. The chest pain is gone, and honestly, I feel better than I have in years. But more than that, I wanted to thank you for something that has nothing to do with medicine and everything to do with it at the same time. When I spoke up in that pre-op suite and told you you'd made a mistake, I wasn't completely sure I was right. For all I knew, the hospital had already handled the name confusion, and I was just being paranoid. Part of me wanted to just trust that you all knew what you were doing and keep my mouth shut. But you made me feel, from our very first interaction during rounds, that my concerns mattered. That I wasn't just a body on a gurney, but a person with thoughts and fears and the right to ask questions. You treated me with respect and dignity, even when I was at my most vulnerable. And because of that, because you'd established that relationship of mutual respect, I felt safe speaking up when it mattered most. I've been thinking a lot about what makes a good doctor. It's not just knowledge, though, that's obviously important. It's not just technical skill, though, that matters too. I think what makes a truly good doctor is the ability to see patients as partners rather than problems to be solved. To listen even when listening is uncomfortable. To question even when you think you're right. You have those qualities, Dr. Reyes. Even as a first-year resident, even when you're probably scared and uncertain and exhausted most of the time, you have the things that matter most. Don't lose that as you gain experience and confidence. Don't let the system grind away your empathy and humility. Stay the kind of doctor who listens when patients speak up. The medical profession needs more doctors like you. With deep gratitude, Gerald Thomas Wallace, P.S. My wife says to tell you that if you're ever in our part of town, you're welcome to join us for dinner. She makes the best brisket in the state, and after everything, we'd love to feed you a home-cooked meal. I read the letter twice, then a third time, feeling emotions I couldn't quite name welling up inside me. This was why I'd become a doctor, not for moments of dramatic heroism or brilliant diagnosis, but for this, for the quiet realization that I'd made a difference not just in treating disease, but in honoring the humanity of the person experiencing that disease. I folded the letter carefully and slipped it into my white coat pocket, a talisman against the inevitable difficult days ahead, a reminder of what mattered when everything else felt overwhelming. Around me, the hospital continued its perpetual rhythm. Monitors beeped. Pages crackled over intercoms. Nurses moved efficiently between rooms. Attending physicians gave orders. Residents like me tried our best to learn and grow and become worthy of the trust placed in us. And somewhere in this complex system of technology and protocol, somewhere in the space between clinical expertise and human connection, medicine happened. Sometimes perfectly, sometimes imperfectly, but always, always, with the potential to honor both the science of healing and the art of caring. I pulled out my phone and made a note to myself, verify MRN, always, every time, no exceptions. Then I added another note, one that had nothing to do with protocols and everything to do with the kind of doctor I wanted to become. Listen when patients speak. They're the only ones who truly know what it feels like to be them. The lab results I'd been waiting for appeared on the computer screen. I pulled my attention back to the present, back to the work that needed doing, back to the patients who needed care. But I carried Mr. Wallace's words with me, a reminder that sometimes the most important medical interventions aren't the ones we perform with our hands, but the ones we perform with our hearts. The simple act of listening, of questioning our certainty, of maintaining humility in the face of our own expertise. Because in the end, the difference between life and death often isn't found in perfect protocols or flawless systems. It's found in the willingness to hear when someone says, "Wait, something's not right." It's found in the courage to stop, to listen, to investigate even when everything seems fine. It's found in recognizing that patients aren't just bodies to be treated, but partners in their own care, with instincts and insights that matter just as much as any lab value or imaging study. That day, in Pre-Op Suite 3, Gerald Thomas Wallace had taught me one of medicine's most crucial lessons, that the most dangerous mistake isn't the one we make, but the one we refuse to acknowledge might have occurred. And I would carry that lesson with me for the rest of my career, through every patient interaction, every procedure, every moment of certainty that needed to be tempered with humility. Sometimes heroes don't wear white coats. Sometimes they're patients who trust their instincts enough to speak up. Sometimes they save lives not through medical intervention, but through the simple courage of saying, "Wait, you made a mistake." And sometimes the greatest gift we can give them is the willingness to listen.